While she's getting water, I'll just introduce myself. I'm Dr. Maggie Fowler. I am the licensed professional counselor for Cal Allen ISD. I oversee the wellness program for Cal Allen ISD with our students and staff. Um, so we're doing a mental health and wellness series that TChat is helping do presentations for, and we've had a few before, and I've posted the videos on my website. And today's is going to be assessment and treatment of self-injury and self-harm. And we have Dr. Cynthia Garza. She is the assistant professor at UTRGV and a licensed clinical psychologist. And I'm going to turn it over to her. And if you have to leave early or anything, we're going to post this video on my website also, so you'll have a chance to see it and share it to anybody that you need to share it with. Thank you.
Thank you, Dr. Fowler. And I think I have my email at the end. So for anyone who is listening to the recording, please feel free to email me later if you have any questions, or if you would like a copy of this presentation, I'm happy to share it. I am going to go through this. It might take the full hour, so I like to say, please put questions in the chat. If I see a bunch of questions, it'll give me I'll know to stop a little early so we can have extended time for questions at the end. I think these presentations are much more helpful when we can personalize it and ask questions in dialogue. So please feel free, if you have questions or specific things that you're thinking about, go ahead and put it in the Zoom chat and I'll be looking at that. Okay. So we're going to be talking about non-suicidal self-injury, or NSSI, often called self-harm. And with that, a lot of things come up. So I'm going to try to get through several topics that tend to come up. Some of the big ones are, what are common co-occurring problems? NSSI is, I'm going to say, very rarely, if not ever, occurring alone on its own. There is usually a context or a common co-occurring diagnoses occurring with it. How do we assess for it? How do we determine risk as clinicians? And with that, once we make our assessment, what do we do about it? What is the immediate plan of action in the moment, and then in care following? Also, I know we're joining with a lot of different professions, so just like thinking about your role and your responsibilities as a blank. I tried to take a moment to have us reflect on how hard this topic is. It's never easy to hear someone tell us that they're hurting themselves, much less a child or a teenager. I've had young ones as young as 2 or 3 years old hurting themselves, and knowing that they're hurting themselves as for a reason. And so it is very hard. I just want to acknowledge that, even though we're all professionals, hearing those words or seeing it is very difficult. So I want to just recognize that when we're fulfilling our role and responsibilities, it is a difficult thing that really calls us to be able to take care of ourselves. And then just trying to provide resources at the end. I have a couple of examples here of ways it might come up. So you might see it. You might see a student and see scars or see an indication of self-harm. So maybe they didn't directly endorse it to you. Or it might have been endorsed to you, or you might be on somebody's safety plan, whether it be in your personal life or professionally. So what do we do when those different scenarios come up? And just because we're from a university, we love our learning objectives. And so I'm hoping that by the end of this hour, you'll be able to define and distinguish between self-harm and suicidal behavior. There is a very distinct difference. They are not the same. They can co-occur, but we have these different terms for a reason. And then just being familiar with what a mental health provider will do once they encounter a patient with this presentation. I think just knowing even if you're not someone that would do it yourself, I think being familiar with the tools that we use might also help empower you to feel comfortable or more comfortable. This is not rocket science. We have done a lot of research and clinical work to be confident in what we do and what the tools can be. So I want to show them today just so that it doesn't feel like this weird Pandora's box that you're scared to open. And then in general, I just want to review the elements of an effective safety plan. Safety plans have their own history of being contracts or not being effective, being intimidating. And so there are certain elements of a safety plan that we know can actually make it an intervention and are more likely to be followed by both the patient or the student and the family or the friends involved. And so finally, we are going to be looking at your own resources at Cal Allen and what it would look like. For example, I think I have an example safety plan for Cal Allen. All right, let's see if I can play this video. I'm going to show my sound. And this is just like a minute long. 2 minutes.
So, you know those moments when you're worried that someone you care about, your friend, family member, or your child, might seriously hurt themselves, or they're thinking of suicide? Suicide is the act of hurting oneself with the intention to die. It can be really scary to bring it up, and it can feel like you can make it worse, or if you don't do it right, or like you can say the wrong thing. Here are 2 skills that I think can help. When you're bringing a difficult topic up, it can be really helpful to name your emotion or your reason for bringing it up. I'm feeling worried about your safety. Are you having thoughts of hurting yourself? Naming your emotion first can make it easier for the other person to talk about their emotions. The second skill you can use is called thought diffusion. And it's basically acknowledging that we are not our thoughts. We are more than just our thoughts. So instead of saying, "Are you suicidal?" we can say, "Are you having thoughts of suicide?" Or, "Are you having fantasies of dying?" Or, "Are you having the impulse to cut?" Sometimes it's really hard to let go of a thought or change it. And if we think it often enough, it can feel like it's a part of who we are. So by separating it, calling it a thought, impulse, or fantasy, it can make it easier to do something about it. Talking about suicide or non-suicidal self-harm with your loved one is a great way to support them. And it's often the first step to seeking mental health care. Also, one last thing. It's okay to mess up. This is the hard stuff, and it takes practice. The more we talk about it, the better we get. So if you feel like you messed up, just say so. "Hey, I could have said that better."
Okay, so one of the articles that I have referenced at the end of the presentation is written in a way that I think anyone could benefit from it. I think it's like just 7 pages or so. So I encourage you to look through it if this is something that you deal with on a regular basis. One of my favorite things that they say is to recognize your own values and beliefs about NSSI. There is a way of doing this that is more than just reflection. If you look up different models for counselor self-awareness, biases, I think there is a multicultural and social justice competencies model, the MSSJC. There are strategic ways to evaluate your values and beliefs. The ultimate purpose of doing that is to see if whether or not you are unintentionally or unknowingly putting those values and beliefs on the patient or on the person in front of you. We don't want to do that unknowingly, right? And so we might sometimes do that by the words we choose, the facial expression we have, or even just the way we approach the situation in general. Self-harm historically has had a lot of, I would say, critical or negative values and beliefs put on people. And so it's very important to remember that that's not over. And very often people, young people especially, will, part of recognizing it out loud that they're engaging in NSSI, they have to deal with whatever values, beliefs, or even misconceptions the person may have in front of them. That can often be part of the whole process of seeking care. And so we want to do our best to reduce that barrier. Here are 15 of the most common misconceptions. I don't have time to go through them all. In general, I want to say that there are some that I have noticed that teens will say that they have experienced more often than not. I will ask my patients, like I'll actually pull this up and I'll say, you know, a lot of times when we chose to go seek care for self-harm, it didn't go well. Maybe someone, a grown-up, a parent, a school counselor, the person at the hospital, the nurse, whoever they were talking to, put a misconception on them. One of the most common ones I hear from a professional to the patient is, or from a parent to the patient, or a caregiver, or a family member to a patient, is number 14. You can stop if you really wanted to. They make it sound like it's a choice, 100% a choice. In my experience working with people who self-injure, there is a behavioral mechanism to it. There is a habit to it. There is a reward system to it, very similar to addiction. So just because you want to doesn't mean you always do. And then just because you don't want to doesn't mean you stop. Try to think of any of you who have ever attempted a diet, right? Just because you really want to stop eating something doesn't mean you're going to stop. I don't want to compare eating a burger or hot Cheetos in my case and stopping that to self-harm. But if you have even just the smallest conception of how hard it is to stop something that you feel that you should stop, then you know just how much against the current, against gravity it can feel like to stop something you have formed a habit with. I've had people say it's like my hand wants to do it, but my brain and my heart don't want to, but my hand keeps doing it. I hear a lot of patients talk about, like, with their peers being stereotyped. So that's like number 10, being goth or emo. We know that anyone of all types, all ages, all professions, all sexualities, all demographics are self-injuring. We did see an increase among a certain group of Hispanic females in the recent years, but there is some talk too of maybe it could also be who is going to the doctor for it and who isn't. There's also a big misconception of attention seeking, or it being manipulative, or if you see, so these are like number 5, number 7, and number 8. A lot of people will be told that. It's like the boy who cried wolf situation. Oh, she just does that because she's being manipulative, or oh, they want attention and that's how they try to get attention. And so then unfortunately they get if that actually were true, unfortunately then they get the opposite social effect. People stop taking them seriously. They may flat out ignore them when they're saying these extreme calls for help. The reasons people do it can vary, and while that could be one of them, the inability to appropriately seek help and communicate your needs without being in crisis. Because if you think about it, someone is more likely to get help if they're in crisis. So very often I try to remember that even if that is the reason, very often there's trauma behind that. someone did not get help when they needed it, whether it was short or long-term trauma. And they feel that the only way they're worth the burden of help is if they're in crisis. So even if someone has borderline personality disorder or they're having difficulty asking for help without being in crisis, I try to remember that. It can be a reason, but it is not usually the most common. I'm going to be going into the actual reasons later of what we see. So this is just a history. I have this on here just to recognize the misconceptions, the beliefs that we have had historically in our field. There was a time when we did believe that all people who engaged in self-harm was just a failed suicide attempt. So around the 1930s to the 1960s, people actually did not see, NSSI did not exist. They were all under the category of suicidal behavior. And then it wasn't until 1969 that the literature started seeing that actually these people may not be having thoughts of suicide when they self-harm. They may not actually even want to die, yet they're engaging in repeated self-injury. And so it was in the 80s when we started to see that it is its own construct, its own problem that requires its own care. And that's when we really started to see terms like self-injury or non-suicidal self-injury without suicidal intent or ideation, or even a history of suicidal intent or ideation. And I think towards the latter part of the 80s, we started to directly define it. Oh, and I have at the end, so here we are now with NSSI assessments, clinic protocols, clinic procedures, school protocols, and we're moving towards universal screening. I believe at this time we're at 12 and up are assessed for suicidality. And in the PHQ, we ask, have you had any thoughts of hurting yourself? So that kind of will assess for both suicide and self-injury. All right, so these are some reasons for NSSI that we tend to see in our healthcare. And in red is what I have listed. Those are 4 reasons that tend to predict or be higher when someone is more likely to act on a suicidal behavior. So the ones in black are very common. The ones on red, when I hear that, when I ask a patient why do they feel that they self-harm, if I hear these in red, my risk that I am determining for that patient for suicide is higher. Because research finds that these reasons tend to be, they can be more extreme or they can lead to more risky self-harm behaviors. I have a quote here of things that I tend to say, and also in that great article of what you can do when you're looking into reasons, or if someone is bringing up reasons, that might be one of the ways they endorse it to you. I was really stressed out, so I cut. Right? It could be one of the ways they bring it up. They may have many reasons, and that also increase the risk. So even if they're all in the black, if there's many of them, that is also, there's a greater propensity for more frequent behaviors, and eventually the tolerance for the pain goes up as well. Asking someone how it's helpful for them. One of the hesitations that can come with that is that you're validating it in a way that you're encouraging it. Something can be functional or helpful and not necessarily be healthy. There's a difference, right? So if someone is experiencing a lot of stress and their self-harm relieves that stress, that's what we would call a maladaptive coping strategy. It's emotion focused, and it actually does relieve that tension in a maladaptive way. Very similar to having a substance, to using a substance to feel better. Oh, I have a drink at the end of the day. It helps me clear my mind and stop thinking about work. Works may not be the best if it's your only tool, right? If it's your only coping strategy. Maladaptive coping strategies can be emotion focused, thought focused, or body focused. So if someone's having a lot of worrying thoughts or depression thoughts and they self-harm to clear their head. Maybe someone is experiencing chronic pain, so they self-harm to focus their pain in a specific place. All of that has a specific goal in mind and may be helpful. So we're going to talk a little bit about what we do after we identify the reasons that a person self-harms. I hope it's helpful to see this list. It was a lot of words, but if you compare this list to the beliefs or the misconceptions of why, I think it really just helps clear up the picture of what brings someone to self-harm. Oh, I do want to say there are a subset of people who hear about it. They know a friend who does it. I think this is kind of getting at the fear of asking directly about suicide or self-harm. And if we expose it, like if we say, do you self-harm, or just say it directly, like bringing it up or hearing about it can lead someone to do it or try it out, because teens are exploring all the time. There is research on, there are many who have tried it because they heard about it and it didn't work for them and they stopped in that moment. There are many who did it once and stopped. So it's not a common enough reason, obviously, for like peers or hearing about it to be on this list. Not to say it's not one. I just want to say that it's not a very common one. So this is what you would see if someone is diagnosed with a self-harm or NSSI behavior. I think it's under disorders otherwise specified or something like that. We will put non-suicidal self-injury in the list of diagnosis if it is directly something that they're dealing with in the moment, or if they have dealt with it in the past. Someone can relapse on their behaviors. Habits are very strong, and you might, if you know anyone in your life who is living a life of sobriety, they'll count their years, right? They'll count their days. Sometimes they count their days when each day is harder, even if it's been 1,000 some days. I really do see it very similarly. People live with an impulse to self-harm, and that might be because of cognitive, emotional, or behavioral habits, or all three, that came from the function of that self-harm. And so we do track the history of the NSSI, and we try our best to track if it's current. On the right side here, you'll see suicidal behavior. So that's when someone will self-harm or hurt themselves with the intent or the thought to die. So you might see someone with both of these, or you might see someone just with one of these. Behavior is specifically when they're acting on it. So there are many people who live with suicidal thoughts and have never acted on it, have never done self-harm, have never attempted. There are many teenagers who will tell me, oh yeah, I've thought of killing myself ever since I was like 5, but they've never hurt themselves. And so they would not actually have one of these diagnoses. There's another code where we could put ideation. So I hope this helps clear up the differences. Okay, here are the examples of self-harm. Of course, it's not limited to this, but these are the most common. There is some literature on not including the eating or the exercising, because that can go into other disorders, and that other disorder may explain it better than self-harm itself. So binge eating, for example, may not really be characterized by trying to hurt themselves. It may be more an impulse control problem. Same with exercise, that can become part of that group of problems, or it could be its own. It could be the form of self-harm that they're doing. So you just really have to assess for it and see what the function of it is and why they do it. Remember, self-harm is deliberate, so they have to know they're hurting themselves. They have to be trying to hurt themselves. I have cutting at the top because that is one of the most common, but hitting, burning, stabbing, those are other ones. One thing we know is it is a good sign, or it's lower risk if someone has only had one form of self-harm. If they start to expand their types of self-harm, that increases risk because they're seeking other types of pain. To give an example, I'm going to be posting in the chat after this. Actually, I'm going to put it in here so I can have a reminder. There is something called non-injurious methods of non-injurious alternatives to self-harm. I have one list for an example. And you'll see on that list, some of them are more serious than others or more severe. They may create more stimulation. And we also have to be careful with that because say someone's go-to method is cutting, but they choose an alternative that maybe might be more an alternative for scratching, let's say, or burning. That might stimulate a different type of pain and open the door or make them curious about what that alternative is for. So I hope that makes sense. So we want to pick a substitution or an alternative that is directly making sense for the primary method that they would have used. This is something called harm reduction. So getting back at that misconception, oh, they would stop if they could. No, right? We try to introduce new things or substitutions. So before cutting, let's try this instead and see if it satisfies the impulse. You'll see the same, if you look up harm reduction, you'll see it applied for many different types of problems. While you all look at the warning signs, I'm going to grab that handout for everybody and put it in the chat. There you go. This is just one list of, there are many kinds, but I hope it helps to see an example. This is one of my go-tos. And like I said, I don't just like give it to them. I choose one there and then. And if they're choosing one that could stimulate a different type of pain, I explain that. And I explain why maybe a different one would be better. A lot of the warning signs you'll see are depression, right? Or stress, family conflict, lack of support. So yeah, depression and maybe overwhelming anxiety. Just for an idea of how prevalent this is. So there has been, as we have increased universal screening for depression, we have started to see the prevalence of NSSI much more. So universal screening happens in primary care clinics, specialty care clinics, and very often in schools when there's an outcry. And so we are getting a better idea. People also will go to the ER if they're not receiving care. And so this is pretty much where we're getting a lot of our statistics. And we know that suicide is the second leading cause of death among teens. And so very often NSSI accompanies suicide. We know that a lot, like about half of teens have sought care in some way. So T-Chat's a good example. We know that they either spoke to a school counselor or a therapist, so that's a call on us. We know that in the year prior to the attempt or the behaviors, they had help. They had encountered one of us. And so that's why I really emphasize those conceptions, those biases, or even your own self-care when you go through those moments, because you could be that person that they saw the year before they acted. No pressure, but it is the job that we do. And so just being very aware of just the sheer amount of people who do seek help and they are trying to stop it. This is just one of the biggest fears. And so I do want to encourage you all, if you have not ever directly asked about suicide, practice it. Are you thinking about suicide? Are you having thoughts of suicide? Have you self-harmed before? When's the last time you self-harmed? I know you told me you had self-harmed. I'm worried that you're self-harming again. Practice those sentences. I remember when that word was scary to say out loud, and we'll walk around it, right? We'll try to talk about it without saying the word. So if you have not ever asked directly, practice doing it. The person that needs to hear that question it is beneficial to ask them directly. I had a case just this week. Unfortunately, I had a psychiatrist who asked them directly, and I had pretty open therapy sessions throughout that I had not been asking directly. It was historical. It had been years. But this is a great psychiatrist who does a lot of questions during her appointments. She asked the teen directly, and it was only then when the teen started to endorse recent behaviors. We can forget to be asking directly. So I just want to recognize that this is a need. It's one of the core things that we do in care. So one thing to know, so when we're determining risk, right? One thing to know is the repetition of the behavior, the frequency of it. It increases the risk because pain, the tolerance for pain is also increasing, as is the fear of death. The more someone can self-injure without harmful physical effects over long periods of time, the more likely they're going to increase risky self-harm behaviors. So this is just an example of something you can ask if you know someone has been injuring themselves for a long period of time and you want to determine the risk of that. These are a bunch of tools. This is why I wanted to offer the presentation, so they all link to different tools for assessing. I think every school district has their own. Most of the time it's the Columbia, the CSSRS. I'm going to briefly go into the ask model today just so that you all can see it. It's one of my favorites because it gives direct things to say. And sometimes that could be very helpful because it's a stressful situation. And the person in front of you knows you're reading through it. So that kind of helps both parties a lot of the time. And then I'm going to show the SOARS model. It's one of the, that's the article that I was referring to. And it kind of just walks someone through what you do when you have someone who's self-harming. I also have just an article that's come out from our Texas Youth Depression and Research Network. It's another arm from TCHAT, from our consortium. And as part of our research, we specifically focus on this. How do we ask about it? What do we do once we get a positive endorsement? So I think we've been in this now for about 3 years of data where we've been following kids and teens who present with NSSI and suicidal behaviors. And we're working on risk management protocols for the state of Texas. So what can we do as a state when we're seeing these endorsements? We're getting to a point where we're going to start recommending treatments or protocols. So it's very exciting. Okay, so there's what we do and then how we do it. And these are just some general things to keep in mind. I like to go over these because you may not walk out of this feeling like you helped. You may not walk out of these appointments or these interactions feeling good. And so one thing I personally do for myself to keep myself feeling okay is remembering that as long as I followed these things, as long as I took this approach, I did the best I could. right? So if I followed a tool, if I used an assessment, if I follow these general guidelines or recommendations for your approach, that's the best I could do as a professional. And that just helps my worries or whatever feeling I have that can contribute to burnout or can contribute to what we call moral injury when we feel like we're not doing what we should be doing. This kind of is how I use this little checklist of things. And so one thing, we do go through a series of questions, not just a yes or no question. Because if you just do, hey, do you cut? Someone just has to say no, and then that's it. So we do, in general, a lot of the protocols have a series of questions, and that helps the child or the teen know that they may lead up to one that they are gonna say yes to. There's also what we call a psychosocial model. So we look at all the different parts, domains of their life, to see what can be playing a part for the reasons that they hurt themselves. We do have that medical dispassionate demeanor. I have a little X on that really nice looking woman who has her hand on that kid's shoulder. We're not going to be this nice little aunt that's like, okay, mijita, let's talk about this. If you take on that approach, as warming as that can feel, that child or teenager may feel like they don't want to worry you. They may react to you in a way that they react to their family. And so we want to give them the opportunity to talk about this difficult thing in a respectful, calm, and dispassionate way, because it might be easier to endorse it that way. They hopefully have those people in their life that will give them that hug. And so we didn't want to add like another component that may make them worried about how you're going to react. And then in general, I think that just helps kids see that you're just trying to understand. You're just trying to see. You're not trying to fix it all right now. You're just trying to see what's going on so that you can assess it appropriately. That curiosity. Addition is greater than subtraction. That's a very common saying I hear in therapy. So that misconception of, hey, you would just stop if you could. Usually we stop doing something when we've added other things to substitute or to just remove the need to do the original unhealthy thing. So always remember, our job as a therapist, as a clinician, is to add healthy and helpful coping strategies. There are a lot of healthy coping strategies that may not be helpful for that moment. So we need both a healthy and a helpful strategy. It's going to take some time to find it, just like how it can take time to find the right medication or the right dose, right? So I always tell kids, try it at least once and see if it helps in the moment. And if it didn't help in the moment, can you try it at least one more time?
Dr. Garza?
Yeah.
Just sorry, there was a question in the chat. It says, how can parents approach this with their child?
So in general, I know saying not to be, I don't know the right word, like to not be so consoling and warm might feel weird to tell a parent that. I think this is a lot the approach that we take on as professionals, but a lot of these we can do as parents as well. So for example, the next one, the non-stigmatizing person first language, not labeling, that was in that video that we watched. That was a parent focused video for how parents can talk about it with their kid. I have spoken with parents about taking on a different approach when they're asking about cutting. So, hey, I'm worried that you're cutting right now, and I really want to be able to help. So I do think that the more we get used to talking about it, we don't always have to be holding someone or taking on that really, I hate to say compassionate, because it is compassionate to also be asking questions, right? It's not black and white. I have some more on here that are more focused on professionals, but in general, I think a lot of these also apply to parents. So thinking about more than just your kid, thinking about outside of just them and not attributing it all to them. That's the psychosocial model. using language that's more curious than judgmental. And using language that doesn't, and one of the ways we judge is by labeling. So not trying your best to say a person who self-harms rather than a cutter, a person who is having suicidal thoughts rather than suicidal. It takes practice, but I think when parents learn how to do that, it helps their kid feel like they can talk to them more. It's very hard to answer that question without talking for another hour, so I hope it at least helps to hear that. These are just things I've already mentioned that our clinics are doing, and so I'm going to go briefly into one approach. Oh, and I just want to recognize this. So simply telling someone to stop, especially doing that as a professional, but even as a parent, when we do that as a professional, we are basically telling them that when you talk about it, you're just going to be told to stop. So they may be less likely to endorse it to you or someone else in the future. So yes, of course, we want them to stop. I wish I could just tell all my patients to stop what they're doing that's harmful. I wish. And I wish that would work. But maybe that's why I had to go to school for 10 years, so that I can learn other ways to help people change. So I wish it was that easy. And if anything, it could make it worse. It could make someone less likely to endorse things with you. So I just have here the change model and recognizing kind of like what I brought up in the beginning. Remember that change takes time. There are stages to it. And so we add things that someone feels ready to try. So they may not feel ready to stop, but they might feel ready to try this new coping strategy that they learned. All right, so I just want to show a couple of examples of these screening tools that people use. The one on the left is the one that a lot of our districts use, and the one on the right is the Ask. So you'll see, I'm going to be putting them in the chat here soon. You'll see that the Ask is going to guide you from screening for suicide and non-suicidal self-injury, and then it goes into an interview, and then it goes into a safety plan. So I'm going to be uploading the packet here just for you all to have. So these are the different parts to ask. You thank them, so kind of getting at like reinforcing the idea of them talking to you. You thank them for talking to you, and you're going to move on with the assessment because they screened positive. So you let them know that. I'm following up because there are some things that you brought up and that I want to ask some more questions about. When we assess and we're determining risk, this is what we're listening to. This is why I want to remind all of us to think of our role and responsibilities. So if your role is not to do the assessment, not to determine the risk, don't feel like you have to go through all this. I just have this on here so you know, because you might have heard these things when the student was talking to you. So they might have not just told you that they were self-harming. They might have also told you that they got in a fight with their sibling, that they've been getting mad, that they tried this drug for the first time. They had a panic attack recently. Maybe they told you that they have broken up with their boyfriend, or their friends are mad at them. Those are all things that can increase the risk of them completing suicide or engaging in a risky self-harm behavior. Whenever I say risky self-harm, I know all self-harm is risky, but there are certain types of self-harm that lead someone to need medical attention. So maybe someone has been cutting for a long time, but then they are having a panic attack and they got in the middle of a fight with a friend. And so they're less in control of their body, and they might be more reactive, and they might cut deeper on that day and not as safely as they usually do. One of my favorite questions that I just want everyone to know today: do you think you need help to keep yourself safe? So if there's anything you take with you today, take that question. Do you think you need help to keep yourself safe? I think it's one of the most clear, direct, it is a yes or no question, so don't ask just one, but I think it's something that has saved an assessment for me so many times. I've gone through a whole assessment, asked a lot of questions, and then I asked that one. And at first it seemed like they were maybe low risk or denying a lot of things, but then I asked them that one and they say yes. And sometimes that question is the reason I will hospitalize someone. Because even though they've demonstrated safety and they've demonstrated an ability to go to a safety plan, they feel like they need to be watched. They feel like they need to be in a restricted environment. And I think that says a lot. The next step after you go through those things is you bring in the caregiver, oftentimes the parent, and sometimes like a foster care parent. And this is kind of a hard moment where you endorse, where you let the parent or caregiver know what was endorsed. So you might go into certain things that the child brought up. There are specific questions that you're going to ask the parent, and it allows the child or the teen to hear what they're saying. You also ask if you want there to be a private interview, and that might just be a time for the parent or the caregiver to talk about something that they're going through or that they feel that their teen is minimizing or not endorsing. All right. Regardless of your determination of how risky it is, I believe we always do a safety plan. They screen positive on the screener, so we should be doing one. And so I'm going to show you an example of one after this. Just know that this is not a contract. Contracts make people assume that it's going to be followed regardless. This is a plan that someone's going to try to do. And it's going to have a bunch of information on there if they feel that they can't reach out to the people or do the coping strategies that we planned for. This is the step that really is like in the moment, what is the clinician going to do? So in general, there are 4 next steps. Are we going to send them to the hospital? And even when we send them to the hospital, maybe the hospital's full. Maybe there's no beds. Maybe the ER doc disagrees. Maybe they're going to just be sent home. That's why we do a safety plan, because even if we send them to the ER, we don't know if they'll be admitted. Further evaluation might be if we feel that they can be safe for the next few days with their caregiver. So we have what's called a referral, and that's someone that is going to come to them. So we have like mobile crisis units sometimes, or even having an appointment in the next few days. That's also like the follow-up. And then we might decide, hey, you know what, false alarm. Someone said something and we engaged our protocol because we're better be safe than sorry, but we feel that there's no intervention needed at this time. These are some of my go-to resources. Kids like to text, so I usually use the 988 number. Depending on the reason, there are certain organizations that are there for certain problems. So so you could look that up also. I just have a few here. And I think that the crisis numbers will also point them to those organizations if there's a unique situation. Just to show the SOARS model, in general, SOARS stands for Screening for Suicide, Learning the Onset, how long has this been going on? Have this been going on for a long time, and so that might increase the risk? Has it been going on for a long time, and has it changed recently to be more severe? What do you do after you hurt yourself? Have you needed attention, medical care? And why do you do it? And that's when we develop other coping strategies to substitute it. And where are you at in your stage to change? Do you want to stop this? I've had people tell me, no, I don't want to stop this. Even then, we still come up with other coping strategies because it's nice to have other tools that you can use to calm down. Right. So they may not be ready to say yes to that question, but they might be open enough to hear and try more coping strategies. And then eventually that's what we would call the contemplation stage. And then eventually they may try to do one of those coping strategies and change their contemplation to more action. This is something that we also use to determine risk, and it helps a clinician figure out how severe the risk is, so that when we are assessing it in our note, we're able to be really specific about how severe the self-harm is. See how it gets pretty specific on how many days or how many acts they've done. All right, so a safety plan, and we're almost done here. A safety plan will have the first section, the warning signs, thoughts, images, mood, situations, or behavior. I'm going to just show an example. So someone can have a test coming up and they know that test anxiety is something that gets them going. They might have trauma and have a flashback, and that might be something. Even seeing objects that they have used in the past to harm, that could be a situation that brings up a warning. And so what are the next stage is internal coping. And those are things that someone can do without seeking outside help. What are things they can do with their own body, their own thoughts, so that they can try to calm down without contacting another person? I have some examples here. And one of the reasons I wanted to show this is because all these examples, a breathing example, something you do with your body called the Havening method, and then something that involves looking around, a grounding method, 5, 4, 3, 2, 1. Notice that these examples don't really involve thoughts. And so if someone, like these are all body examples, and that's fine. If those all work for the person and that's what they need to do, they need to calm their body down, and that's the type of problem we have. But we do try our best to have a variety, because if a body one isn't working, maybe body ones aren't what they need in that moment. So that's one thing I would say. Try to have a variety of coping strategies. And then we start with the people. So we want 2 types of people, or actually 3 types of people. We want people that will distract us, which are often friends or certain family. And then we want people who actually know what's going on, because the people who distract us may not know why they're distracting us. They just are funny, or they play video games with us. Maybe there's someone we hang out with. It would be nice for them to know, but very often they also are just people in our lives that distract us. Then there's people who know that you're going to call because they're on your safety plan. And so those are very often family. And then we have our professionals. So if you see this example, this person put their family members for both. And then they also had their therapist and their school counselor. The next group of professionals is actual services. So see how I think for your area, I put this information here. So you have the phone number and you actually have the address, so that if someone wants to physically walk into that place, you have the address right there. And then at the very end, step 6 right here, what are you going to do to make the environment safe? So sometimes you do need someone who's living in the home, and what are they going to do around the house to keep them safe? Are they going to keep things in their room? Or are they going to keep things in a locked place? This is a chance for a child to say, I have right here, Dad locks and hides his gun, but I know where it is. Dr. Garza, can you go tell him to move it? It's a chance for them to say things like that. The safety plan ends or begins. I like to do it at the very end. What is a reason for living? If someone can't answer that question for me, I take that as a moment to say, hey, I know we have this plan, but it sounds like you don't have a reason for living right now. It is very hard when the thing that they choose is something that feels small to you. But remember that it's their reason, and they're answering it honestly. It is pretty obvious when someone can't answer that question. So after it's done, I have them get their phone out. They usually have a phone, or I get the parent to get their phone out and take a picture of this. I email it to them directly, but I make sure they have it on them, and then I make sure they have all these phone numbers in their phone. So that's something that's very important. Like, can they actually call these people? So all the phone numbers have to be listed on here. If they're not on there, it's not an effective plan. These are just some therapies that can help that you might have seen in the past. Motivational interviewing is helping them going from that contemplation to that action. We do a lot of CBT for thoughts that don't help the situation. DBT is very often used when there's relational stress or problems with emotions that impact our ability to seek help. And emotion regulation group therapy, I don't see that very much in our area just because of the services we have, but you might see it at a facility. Like if someone is in an inpatient facility where they go stay somewhere for an extended period of time, very often there's like a group therapy, and they'll practice seeking or practicing emotion regulation with others. Accepting your emotion, accepting that you're mad or sad about something is always the first step. Because if you're not going to accept it, it's going to come out in some way. So that's one of the things that one will focus on. In general, I wish I had examples of coping here. I think this article has it. So there's a great table on like, here is the reason you do it. What is something that you can do instead of self-harming? So you might bring that up, but as a therapist, it's an interactive way of developing that coping strategy. I try not to tell people what to do. The skill of being able to come up with it on their own. What are things you've done in the past? Or what are things that come up for you right now when you think you can do something to feel better that doesn't involve self-harm? It's the whole teach a person to fish thing, right? If they can come up with a coping strategy on their own, I don't care if it works, if they can come up with it, that ability to practice something and try something new and come up with it, that's something that's going to carry them throughout their lives so that they won't always need you, right, to get through a problem. That's how we come up with coping strategies. Now, yes, I have a bunch in my little toolkit that I try to bring up if that's hard. But that's why it's an interactive thing that we do in therapy. These are some general resources and research networks that are working on this. There's a suicide prevention hotline in general. There are a lot of people working hard to figure out better ways to prevent it and identify it when it comes up. All right. I think this is my last question. We have about 5 minutes. Is there anyone who has any questions or thoughts about this? I'm going to use this time real quick to put those documents I mentioned. All right, I am uploading an Ask packet. It has all of the things I was reading on and a copy of safety plan templates that you can use or just be aware of. And then I'm also uploading the source article. Give me 1 sec. Stop sharing so it can be easier. And if Dr. Fowler, if you want to reach out to me, I can send all these to you too if you want to have them somewhere.
I am downloading them as you
Nice.
put them in the chat, and then I'll post them on my website too.
Here's the source. And source is great for anybody. All right. I'm just going to show this before we go. All right, so this is something that I would encourage everyone to read. It's short, it's very application based, and at the very end, here's the examples of a reason and something you can maybe suggest that someone try instead of self-harming. And I always say that, just try it. No harm in trying it. All right, y'all. I hope that was helpful for everybody. That's all I got today.
Thank you so much. I appreciate it.